All right, we're gonna get going here because I gotta get my beard shaved. I'm looking a little shaggy today. But we're gonna talk about a GentleWave case before I go get my beard trimmed up. We're gonna do a premolar today because a lot of times premolars can be a little bit interesting on how they line up and even like the access that we wanna make them. Sometimes you feel like when you put the positioning jig on it, it's like a stovetop. It's just super high. So I'm gonna just show you how I do that. I mean, early on, I'd always wanna leave that flush down to the cusp tips, and I find, but I don't want to make my axis that big. And so what happens is it just the positioning guide just sticks up a little bit higher, and I'm going to show you how I build that up. So I thought it was an interesting case. It's also an interesting case because of how the sinuses are involved. So let's give it a go. It's actually tooth number 4 we're going to look at, and I'll just walk you through the case and kind of the decision tree here. Kind of interesting. All right, so here we go. Root canal number 4. So again, when you look at this, you can see that the outline of the sinuses are up in here. And it just makes you wonder, are we dealing with something that's directly into the sinus? So obviously a 3D exam would be paramount. It would be super important. Occlusally, we see a facial filling and a distal occlusal filling. And, but all in all, the margins look tight, so I'm not worried about leakage. And so I want to keep my access as small as I can. Again, I can see the Schneiderian membrane. I'm going to run through my diagnostics just looking at this cone beam really quickly. And the main thing is I'm looking for any potential communications from an apical delta or that terminus, and would I have a breachment occur into the sinus. And so that's one thing. I'm also paying attention to this thing looks very locular, and potentially maybe there is a cyst formation going on. I don't have a lot of history as far as duration goes, but those are the things that are running through my mind. Duration meaning how long the tooth's been symptomatic. Patient was unaware if there was a problem. In fact, this was a silent case, so it was not a symptomatic apical periodontitis. So I use the butterfly clamp, and that's been put on, and you can see me kind of working down here. I also always use that caulking. I think it's just something that I just love, so I use it. Kind of pushes the rubber down apically. I'm using just sort of a 157L style burr, and I'm just gonna kind of go through this and then make my little access. I'm using a yellow Muntzburg here. And just to see if there's any pulp stones in there, and also to kind of find where where the orifices are. And that's all that's going on. It's just endo 101. So far, everything's smooth sailing. We like cases like that. Pretty simple. So let's keep going here. Just trying to get this thing in a little bit better focus. SX, my go-to initial file. You can see I've done nothing else. I'll pick through stones, I'll find the orphi, I'll just go through it. Finding both the buccal and the palatal canals here. Just gonna tidy things up, get that rubber dam just a little bit tighter around there. All right, so fairly small, fairly conservative access. Lindsay's gonna hook me up here. All right, so we're just gonna get a quick length. Just kind of confirm, I always talk about in other videos that I really like pre-measuring on a cone beam, and I play this little game, measure twice, cut once type thing. And so I don't go full tone on apex locators. I'm not going patency pullback. I'm just actually going down to the reading and corresponding that to my cone beam length. And that's all that I'm doing here. I use an extra long 10 file. It's a 31 actually, just because it's easy to see around and like looking at the marks. I don't always use the rubber stopper. They move around. But on this one, it's taken me a little bit of negotiating. There you saw the little reason why. So I'm considering that there's a delta here or some sort of apical fast break, simply because it's just not really reading correctly, and you saw that little thing that came out here. Taking a length, very short. I think there's a tendency that we all kind of always go to 18 because for the most part we can. Sometimes you can't when they're shorter than that. This is one of those times. A little bit of hand irrigation. And I know from the CBCT that there wasn't like a forked terminus on that, and so you can read both sides. You can read one side, whatever your preference is as far as with the apex locator. What I was reading on that was the buccal canal. I'm perceiving this to be a 2-to-1 scenario at this point. I can see an isthmus in that pulpal floor. Trying to get that in focus to kind of demonstrate that. And so what I've done, because I can perceive that, and I also, these canals are pretty big. It wasn't until the terminus that I was even twiddling with that file, I decided to go right to the 3D shaper because I could. And I'm going where this goes. And that's really all the instrumentation I'm going to do. I like the 3D shaper. I do think mechanically it gets into interproximal or isthmus type areas. And I'm just going to flush that out, and that's that. So all I've used is an SX is Discovery, and then a 3D shaper down to that apex locator length, which was also confirmed on the CBCT. And now I'm going right to the GentleWave. So I'm taking alcohol, cleaning the environment, very important. I don't want any protein, pellicle protein, plaque on the tooth or crown, and I'm just drying everything up. I don't want any residual hypo or anything like that around the tooth, just so that the sound seal really sets nicely. Great. All right, so now here it goes, and this is what I was describing. So that matrix is sticking up pretty high. If you look around that, there's, it's several millimeters up above. It's just barely going in the access, and that's what I wanted to do. I didn't want to open that up so that platform touched cusps. And so what I'm doing is I'm taking the sound seal, and I'm going to come in using both my hands here. And I'm just injecting actually up. I'm injecting up on the platform because the platform is really smooth and it spreads bubble free the sound seal around. And then I'm going to try to do that left-handed now. I switched my hands and I'm coming up under the other way. And so left-handed, I'm just doing it under the palatal side. And I'm just, again, injecting it up. And realize mud pies are where it's at. Like, just make the freaking mud pie, and you get a great platform out of it. So that's all I've done, and I'm going to do a quick cure. Now, I know I always can come back and add if human error occurs here, because it's really easy just to patch. So we get a little cure, and when I cure, by the way, I'm trying to do this looking at indirect. I actually don't mind touching the platform. I think the heat actually is my friend, the heat from the light. And I don't want to like bury it into the sound seal and do something like that. So I don't want to touch that, but I have no problem touching the platform. And sometimes I wish that even my hemostats were clearer. We had tweezers that were made of the same stuff, and so I could just cure around it a little bit easier than cotton pliers or hemostats. I just like the grip of the hemostats. I just feel like I have more stability when I'm wanting to do things left-handed. So that's why I use that over cotton pliers, but there's locking cotton pliers, of course. And then once I've done that, I always go a final cure right on the occlusal table, especially since I've stovetop this thing. So I'm gonna let this puppy just get hot and set. And you can see I've got a nice ring around the collar, a nice little impression. But there's a void. So let's see what I do here, or not. You could probably get away with that, but I don't like probabilities very much. Never liked statistics much. No probabilities, so we can just add to it. And sometimes that's why I like showing these things, just to show you whatever your temperament is, do it your own way. I know that still probably would have worked, but maybe not. So no probabilities here. So I'm just going to place that platform back. I did not pre-cure it. I flushed it, and then I'm just going to seat it down and give it a go. You can go a little light on that, or excess will kind of push back around the matrix. Or if you just want to kind of like impression it in, just go a little light. and cure it, and then you'll just see a tiny bit of an outline, but enough to create the silicone to really make up whatever difference is there. Now there's a debate whether you want to go re-access or not, and corporate actually says you don't need to sort of take the flashing out. I just can't do that. I feel like I watch the bubble close, and when I feel like there's any undercuts or something like that from sound seal in my access, I feel like it's not a smooth flow, and it affects that bubble. And I could be making that up in my head, but it's what I feel like. And when I do this, I just usually get a consistent bubble. I just feel like I'm really controlling the energies of the MOA, mechanism of action, correctly. And so I like to just kind of finesse the sound seal. It's very soft, so I use a slow speed. I'm not really trying anything. And I'm noticing, just trying to see if there's any air pockets or bubbles there. And I felt like there was one right there, and you probably saw that. So I'm just taking some more sound seal, and I'm just gonna put that in and then just smooth it back up against the wall. And again, it was kind of part of where that little gap was up kind of coronally. So I just felt like I wanted to close that off. And again, I know there's sound still beyond that little bubble, but I like the flow. I like a nice exhaust pathway, and so that's what I do. And I'm stovetopping it, so I've really lifted the depth up there. But it's not hard. I mean, it's super easy to do, and we work under microscopes. You know, patching a perf repair is way harder than this. So there we go. We give that a last cure, and now I've set that up. So really minimal instrumentation, a little bit of finicky on the sound seal, and I've just become that guy that's going to spend the time up front. And then I want to just see, when I look in it, that I can see both orifices in that, and that's what I could see. So just the buccal, lingual, facial palatal, whatever your terminology like is, and that's it. And then we let her rock. We just let it flow. And it's going to go through the degassing phase. I mean, the procedural instrument, although it looks different than the molar, it's the same. It's just that cavitation's happening in the head of the handpiece. You can see Lindsay wiping that down over here in the corner. Passing it back. And then it'll just splatter on it again. Hard wiping work is all for nothing. Wipe it again. It's like your windshield wipers, right? You want to just wipe it all the time. Spin your mirror around, make it go clean. You could do that. Rotating mirror, right? Rotate the mirror, keep a little bit like a fan so it keeps the splatter off. All right, so if you look in the red box, that got left off one of my last videos, drove me nuts actually. So we're 18 minutes into the case. You know, when I'm watching, you know, if there's any leaks around the silicone, you just suction it up. We got a little bit of splatter. But I'm really actually watching that dancing bubble. That's the energy employed. So that's the fluid dynamics employed. But then around that, and kind of back up through the procedural instrument, is the exhaust. And I always want to watch that as well. I want to watch for pink. I want to watch for pus. I want to watch for air bubbles along that. So it's really important to pay attention. I know a lot of people talk about perhaps having their staff do it, and they feel very comfortable having them do this, more so in the molar. And I think maybe it's because there's a little bit more wiggle room when you have that silicone. It just seems squishier, and it seems like you can have a lot more wiggle room on that, and that might be why you're more comfortable with it. But I tend to hold them. I used to let them hold it, but then I kind of got obsessed of trying to master this thing, and so I hold it all the time. You can see Lindsay up in the corner up here, and she's actually typing my notes. So her goal during this little 8-minute cycle is to get everything done, everything saved, the final x-ray. That way we're really efficient, and we're trying to just get everything A to Z done in under an hour. Really my goal is 45 minutes, to be honest. I schedule an hour because of anesthetic time and talking time, paperwork time, stuff like that. But if I'm in the 46-minute range, I go by rules of 8s in my head, 8-minute cycles in my, or steps in my head when I do the GentleWave. But a lot of times I'm getting these things under 40 minutes, so in the 30 range, which is good. I like it. It's a great workflow. You could also use this time to get up and walk out, do a consult check if you had that in your schedule. And a lot of times that's what's happening to me. But again, I've found that other workarounds for the consults, I tend to do them during anesthetic now instead of during the quote-unquote working length, because I'm not doing working lengths like the same. But if I do a working length, I will also do a consult then, and that keeps my butt in the chair during the GentleWave procedure. And then the trade-off, that's when the assistant's doing the notes, because they have nothing better to do unless I want them to suction a little bit or wipey on that mirror. See, she heard me. She wiped right then. It's a big arrow. Could scratch my hair right here. Okay, almost done. I know it seems like we're watching weeds grow. Oh my gosh, but that's how it goes. I'm not that funny of a character, so you could be telling jokes. The problem, if you're really funny, your patient's head will be bobbing. So don't be too funny, just funny enough to keep your staff engaged and your patients from falling asleep, or let them fall asleep. Then dancing fairies and sugar plums in your head. Only around Christmas though. All right, we're coming to the end here, I promise you. Time to wipe the mirror again. But you know what? This sort of boring scenario that we're watching is actually good. You don't want events during this. You want it to just be predictable. And I find the way to make it predictable has to do with how you build the platform, which is why I wanted to show you the Stovetop here and just kind of a nice way to inject. Obviously, I wasn't perfect because I had to do some patches, but big deal. Adds a minute. Lindsay's catching the exhaust with, because I told her to, because I was getting annoyed with the specs on my mirror. She's done with her notes, so I can do something with her. How pretty. So again, very consistent. The bubble is just right there. You know, honestly, most often, I find with there is a little bit of a hum, a little bit of a sound that goes on. And I really do fall asleep. It's not unless they're watching my TV in the ceiling or laughing at something on TV. They're really just like mesmerized by it. It's like white noise, kind of puts them to sleep. It's kind of soothing. But the question is we had that little apical block, which I call the delta. Likely it was where the 2-to-1 was coming in, and you saw me pick around that with the apex locator and hook something out as it kind of bent the tip of that 10 file. It'll be interesting to see what the GentleWave does in that anatomy, as well as in the coronal anatomy right there at the floor, where we saw kind of that isthmus connection between the buccal and the palatal canal. But you know, things are stable. The disadvantage of a double-winged clamp is a lot of times that buccal bow, the bow that's on your mesial side, I should say, not buccal side, but the mesial side, it can feel in the way. So I find myself using longer instruments when I use that. So whereas I would normally be using a 21 file, even though this was short, I'm still using a 25 file just for convenience over that bow. And I find that stovetopping it, like I said, also makes it easier to work upon the platform for the same reason. It just gives you room so this bow doesn't get in your way. I haven't liked the traditional clamps or the single bow clamps on bicuspids or anteriors as much, but that's the drawback to the mesial bow. So we can see really small access. Could always go smaller, I get that, but small for GentleWave. Conservative, and you can see that 2 cones are touching. And those lengths are right around 16. By the way, I don't know if I told you that. I just said they were short, but you can see on my markers. And there you go, there's that little crinkle. And so I kind of believe this is 2 to 1 and then back out to 2. And that's kind of what I perceived when I was fiddling around with that apex locator. So, you know, 2 to 1 to 2 anatomy. And certainly this sort of very locular type lesion at the terminus up here. Notice there was no sinus involvement. We did have a true outline of cortical bone. We did have Schneiderian membrane over the top, so I wasn't worried about any sort of breachment going on into the antrum there. And in cases like that too, you know, at this point when I was doing that microsuctioning, you could find edema, you could find straw-colored fluid if it was in sinus fluid or a cyst or something like that. You can see that that isthmus is opened much more than when I just took my instrument at the beginning, and that was a 3D shaper, by the way. I didn't do a ton of instrumentation, just enough for fluid dynamics, but it removed it. It's gone. So if you roll back in the video, you can superimpose. In fact, maybe I'll do that. Maybe I'll take a screenshot before and after of that and just put them side by side here for you. But you can see that that isthmus is open. So isthmus clean and the bicuspid. So saline's my final wash here, and a lot of times I am binding the needle and extruding it if it will extrude, just to see what comes out, and also to just control any bleeding or initiate a blood clot. And then after that, it's just paper point dry, and then obturation. So longest part was the GentleWave. That's what it felt like. But time-wise, it's very, very short. We're under, you know, probably just going to be over 30 minutes on this. Now you can obturate to your liking. I inject, I've been asked this quite a bit because they look at this little navy tip and this amber colored compression syringe that they ask if I'm using Endores. I'm not actually using Endores. I usually use AH+, so ribbon, and or BC. Kind of go back and forth on that, depends on the circumstance. I feel like if I have a lot of apical activity, I'm favoring bioceramics. I'm favoring bioceramics in resorption type cases. And I think people maybe just use bioceramics exclusively. I don't. I still like kind of the epoxy-based sealers. And this one's actually ribbon. You can tell because it's got a little bit of a yellow color to it, whereas BC is very white. Now, I'm not criticizing Endores, I just haven't really fallen in love with it. Actually, I have one doctor in my practice that actually quite likes it, uses it quite a bit, claims that it flows better than anything, even better than than using bioceramics. So in his hands, he favors it. But that's why you guys are doctors. You can do what you want. You know, I oftentimes feel like we're judged by the way that chamber looks, the access chamber looks. So I do like to burnish it down really nice, and sometimes I'll take a burr and clean things up. And I usually will clean up all the sealer and everything before I put the sponge. So just the first thing my referring doctor looks at is a nice clean access. It's important to me. The other thing, if you go back and look at the x-ray, we had those fillings. They did not leak during the procedure, which is great, which means there's no secondary caries going on. Now, my bendy brush that I'm using is just a yellow, and that's about the width of the access. It's not a wide brush, it's just the standard yellow one. I think it's like a 2 or something. But anyways, I'm just cleaning up that with isopropyl alcohol. You can go one step further and take a conditioning agent. I don't acid etch, but I like the conditioning agent because it just kind of cleans up the residual. And that's why I like it if I'm doing a bond, but I tend to use it even when I'm not actually doing a permanent filling. But when I am like this, I'm going to really spend some time cleaning that up. So I don't have any communication of ingredients with my bonding technique. So that's why I like a two-step technique. A lot of guys like one step, but maybe they're counting an alcohol wash or a water rinse if they get it off not as a step. I count that as a step. So I kind of do this as a prep work, and then I will place my bonding agent in. And if you look, I am actually putting it over the occlusal table, frankly, because if there's any activity or affected dentin in that connection between composite and tooth, I at least want my bonding agent to fill it up. And I'm talking on a very small level because obviously it withstood the GentleWave. But if the GentleWave microscopically opens something up, it makes me sleep at night if I can actually just kind of go over those margins of the filling and just put bond over the top of it. I don't know if that matters, but it makes me feel good. It probably doesn't, but I don't know. We got to get someone like Capasalo to look at that for us. But I think it's an important question to ask. And then this is such a small amount. It's only a millimeter, maybe 2 millimeters deep. And so I'm doing this in one solid bulk fill. Then I'm just taking a glick and I'm going to just kind of drag it up the cuspal contours just to try to get good closure. And that my union to the composite and to the tooth is tight, so I'll drag it. And I find that slower the better. I mean, you don't want it to actually set completely. It is a comprimer, so it does dual set. But I will drag it almost when it's partially set because it kind of will drag up against the wall. And then I'll just set it. 32 minutes in. All right, so now that that's cured, we'll take a look at it. And sometimes if it sweats, you can re-cure it if you feel like it's not. I'm just taking a little round diamond, making sure there's no flashing or excess bond. If you got a little liberal, a little juicy with your bonding agents, you can take off that because it will cure and just be rough to the touch and it will mark. So I'll just kind of make sure there's no flashing up there. Take a look at this thing. Do a little occlusal check. Yeah, the problem when you do put the putty, you have to clean it up, but I don't mind that. All right, I want to make sure that's not in contact. We look good. And there you go. So you can see that kind of just the occlusal axis is a little bit narrower than the floor where the two canals come in. Certainly this is what I was filling here at the end with that little bubble, that kind of the 2 to 1 back to the 2. And so the GentleWave really opened that up and it really was like a resorption there. I don't believe that part is extraoral or extraradicular. Then you can see the little tunnel and then the little sealer cap that's over the top of the root there. And that's that. So, the next step is just follow up and watch that lesion shrink up. One of the things that we want to start doing is we'll be putting our recalls up here so you can see the outcomes, 3 months from now or something. So stay tuned and we'll get a notification to you when those go up. So if you subscribe to us, then you'll just know when that kind of that finishing recall comes up for the x-ray would be great. So there's the start and the end. So if you notify, just tap that bell and subscribe to us, like I said, when we get those post-op 3-month, 6-month recalls and we can watch the lesions shrink, and I'll do a quick little narrative or an update to these videos so you can follow their progression. That might be kind of nice and interesting to do. So just that's why you want to subscribe to us. Ask your questions. We're happy to answer. And Till the next time, thank you.